knock on the door. Hi, Mrs. Ford. I'm Bailey. I'm going to be your nurse today. And we're going to go ahead and check you out and see what's going on with you, see what's wrong. Before I do my QSIN, can I ask your name and date of birth? Okay, and I'm going to check your wristband. Okay, so it's all good. We've got the correct staff names, the board. You are on a ventilator. So I'd want to just double check, make sure that the flow rate of that is correct, and the plate, I'm going to make sure there's no complications with that. Feeding tubes, you do have an orogastric tubing, so you just want to check the placement. I would just check the placement of that. I can listen to the stomach with my stethoscope and put a puff of air into the tubing and listen for that puff, the puff sound. And also, if that didn't work, I could always pull back for the gastric contents and check the pH, or I can do the x-rays. So we don't have any abdominal tubes, but we do have a drain. You have a EVD drain, so I would just go ahead and would check the drainage on that, how much, I want to know what it looks like. And like I said, the amount, and make sure that it's compressed enough to make sure that it's going to be able to drain. We don't have any chest tubes, tracheostomy, don't have a trach in, Foley catheter. We haven't put in our Foley catheter yet, but we will, and when we do that, we're just going to want to check or make sure that we write down when we inserted it, make sure there's no kinks, make sure the drainage bag is below the bladder level, note how much is in it and what the urine looks like. And the IV saline lock, you have a saline lock in, and I see that's in your right arm. Don't see any redness, don't see any swelling or tenderness, any no drainage. We would want to make sure our IV is connected to our bag and that it's labeled, or, well, we don't have a bag yet, it's a saline lock, but just, and then our side rails, we've got 2 side rails up, our bed's in low position, call lights in reach, obstacles, there's no obstacles in the way for the patient. Patient's assistive devices are at their bedside. Water pitcher and cup is available. It's clean and full. Urinal, you don't need one. And you have your toilet, bedside commode next to you. There's nothing in it. And trash bag is attached to the overbed table. Alright, now I'm going to go ahead and take your vital signs. So I'm going to take your temperature. I'm going to take the pulse. Look at the respirations while I do the pulse. I would take the blood pressure and pulse ox. And then our temperature was 98.9, your pulse was 84, respirations were 16, your blood pressure was 124/68. And then also they looked like they went ahead and did MAP is 86, and then your ICP is 12. And before I do my head-to-toe assessments, some things that I can look for diabetes insipidus, or some of the signs and symptoms, are extreme thirst, producing large amounts of diluted urine, frequent need to get up and urinate during the night, dehydration, electrolyte imbalance, fatigue, and malaise. Alrighty, so grab my stethoscope. Alrighty. Just gonna go ahead and look at the face. Okay, everything's symmetrical. I'm gonna check your eyes here. Look at my finger. Go side to side. Pen light. Okay. And I did have to open up her eyes. Now my patient is a little unresponsive, so I'm gonna see if I can wake her up. So she seems to, I did a Glasgow coma scale, and she was at a 6, so that means she's comatose. She did pull away from pain, and she can't open her eyes. Her pupils were equal, reacted bilaterally, and they were 4 millimeters. So, so she couldn't tell me her name. She couldn't tell me her date of birth. Well, she couldn't tell me her name, her date of birth. She couldn't tell me where she was at. So, and push-pull is absent because her LOC is decreased, obviously. So I'm just going to go ahead and feel those pulses bilaterally and check them. Okay, and then I'm going to do the cap refill on both of the hands. Okay, it's less than 3. And then I'm going to go ahead and I'm going to listen for the lung sounds as much as I can with the patient's regular breathing. Listen, all the spots. Listen to their back. Okay, and I'm going to try to lift up their right arm. And try to lift up their left arm. Alright, and then while I'm at it, I'm going to listen to the apical pulse. Okay, so lung sounds are clear. S1 and S2 sounds were heard. They weren't labored. Breath sounds weren't labored. Okay, so then I'm going to go ahead and palpate the abdomen, or listen for the bowel sounds. And notice my patient's face when I do palpate, if at all she makes any facial expressions or if there's any pain. Okay, I'm going to feel around. Okay, so bowel sounds were heard, which is good. It means the orotrach tube it's working, or orogastric tube is working. There was flat, no distension. Patient didn't show any signs of pain. So then I'm just note that when I looked at that drainage tube, I see that there is pink, and it's a pink clear, and there's 6 milliliters in that. Right, and then normally I would ask my patient if she was able to, if last time she had a bowel movement, if she's passing gas, if there's any tingling or numbness in her arms or fingers. Then I'd ask the patient about how they're having any frequency, urgency, pain, or going to the bathroom, but they did note that she has had, or we've noticed that she has 120 milliliters of clear yellow urine. Okay, so also when I do if I'm looking through the orotrach, my orogastric tubing, I just want to make sure I look in the mouth, make sure there's no irritation, and I don't see anything that looks abnormal, and make sure their mucous membranes are nice and pink. So now I'm just going to check their bottom half, check their legs. Everything looks good. Okay, I'm going to have the patient won't be able to do the push and pull with their feet, but I'm going to check their cap refill bilaterally. It's less than 3. I'm going to feel their pedal pulses. Pedal pulses are present bilaterally. Okay. So now, alrighty. Alright, so I did have to do this in a separate video just because I don't have any other hooks in our bedroom or anywhere else other than the bathroom, so just combine it with the other video. But so our patient was prescribed normal saline running at 75 milliliters an hour. So I'm gonna work with the stuff that I have. All I have is a IV piggyback bag, and I only have secondary tubing. So I would walk in, introduce myself. Hi, I'm Mrs. Ford. Or hi, Mrs. Ford. I'm Bailey. I'm your nurse from earlier, and I'm gonna go ahead and be giving you that 75 milliliters of that normal saline. And what that does is it's just going to hydrate you, keep you hydrated. Are you allergic to anything? Okay, and I'm gonna ask for your name and date of birth. Alrighty, and I want to make sure, double check that I've got the right solution, the right bag, so normal saline. And I would make sure to put on some gloves. And before I do anything, my patient does have a saline lock in, and I'm going to want to check the patency of that saline lock. So I'm going to go ahead and look at your saline lock. I'm just going to see if I see any inflammation or redness or any tenderness. Right. Get these gloves on first. Also, I need to make sure my door is shut too. Make sure I provide privacy for the patient. And we're just going to look at your saline lock. So I don't see any redness, inflammation, tenderness, or infiltration or anything like that. Oops. So I'm going to go ahead and start the infusion. So what I'm going to do is just take that bag and take off the top. And I'm just going to spike it through, twist it. I want to make sure that my tubing is clamped. I'm going to hang that. And I'm going to squeeze my drip chamber to about halfway full. And then I'm going to go ahead and prime my tubing. Do it over a trash can or sink or whatever, and make sure I'm getting all those air bubbles out and that I don't see any. So that, and then I would go ahead and secure it to my saline lock, making sure I wipe off the cap with a sterile swab and connect that through. And then I would want to set my pump flow rate at 75 milliliters an hour, and then come back in an hour or so, check on it, make sure that it's dripping. But before I do leave the room, I want to make sure that I am seeing drips coming out of that drip chamber. Then come back in, like I said, and check on it, make sure it's not leaking around the skin or infiltrating the skin at all. And then I'm going to document that the date and time, the format, state that I observed the skin, or check the patency before, state the type of solution, how much, and how the patient handled it. Alright, so now we're going to go ahead and insert that Foley catheter. I don't know exactly where my kit is at, So I'm just going to walk through the process of what I would do to put in the Foley catheter. So I'm just going to get my supplies. I'm going to get some clean gloves at first and basin, and have the patient put their legs, prop them up on the bed, and spread apart. I'm going to put a pad underneath them, and I'm going to clean the peritoneal area before I do anything, just with soap and water. And then I'm going to go ahead and take off my dirty gloves, start opening the kit. Be careful not to touch anything that's sterile in that box, because everything in it is sterile. So I'm going to set that up, put a drape over top in between their legs, leaving a area for the patient's perineal area is at. And then I'm going to go ahead and put my lube into my box. I'm going to go ahead and set up my bag to throw away everything in. And I would go ahead and put my sterile gloves on. So I'm going to take the tip of the catheter tubing, I'm going to dip it in that lube and set it aside for a minute. I'm then going to open up my iodine, and before I would actually apply the iodine, I want to make sure that the patient does not have any allergies to iodine or any other kind of allergic reactions that they know of, or to any seafood or anything like that. So then I'm going to take a swab and only use one swab per stroke and clean the perineum, clean the labia majora, labia minora, and the meatus. And then once that's done, I'm going to go ahead and I'm going to take that tubing or the catheter, and I'm going to open up the labia, and I won't be able to remove my hands after, won't be able to do that. Since my hand that I used to separate the labia is now unsterile. And then I would insert it for female. You're going to insert it, and then once you see urine flowing, you're going to insert it a little farther, and then you're going to fill the balloon up with 30 milliliters of water and give it a tug to make sure it's in there, and then just clean up around them, and make sure there's no kinks or anything, and that the bag's attached to the immovable part of their bed, and that their bag is attached, or the tubing is attached to their leg, so they won't kink it or sit on it or anything. So alrighty. Great, so Mrs. Ford, I'm going to come in and I'm going to go ahead and get your supplies ready, and we're going to give you some normal saline at 75 milliliters an hour just to help get some fluids in you. So I'm going to come back in and we'll get that all ready for you. Hi, Mrs. Ford. It's me again, your nurse, Bailey. Just coming in to check your urine output. So I've already done 2 so far, and within the past 3 hours, our patient's urine output was at 180 milliliters, 240 milliliters, and 440 milliliters. The urine color is now clear, and it's barely pale yellow. Her blood pressure was 108 over 56, heart rate was 104, and her ICP is at 15. We also got your labs back, Mrs. Ford, and your sodium was at 155. Your serum osmolality was at 310, and your urine specific gravity was at 1.005. So the doctor has prescribed you with desmopressin, and what that's going to do is that's going to enhance the reabsorption of the kidneys, so you're probably not going to be going to the bathroom as much. It's just a hormone. We're going to be giving that through your IV line. Just give an IV push at 2 micrograms over every 12 hours. the side effects you might get is a dry mouth. You might have seizures or hyponatremia. So those would just be some signs and symptoms to watch out for. So would go ahead then, and I would give my desmopressin to the patient through the IV. I prepare it and just give it IV push and do that every 12 hours, and then I would come back in, or before I would give it, I would ask the patient if they've got allergies to anything, make sure I educated them, which I did, and then after I give it to them, I'm going to come back in an hour or so and see how they're doing. I'll be back in, Mrs. Ford, in an hour or so and check up on you and see how that desmopressin is doing for you. Okay, so it's been an hour later. Knock on the door. Hi, Mrs. Ford. I'm Bailey. I'm back. I'm your nurse, you're Bailey, and I'm just checking on you to see how the desmopressin's doing. Are you feeling any of the side effects, such as dry mouth or seizures, or anything like that yet you've had? All right, that's good. Looks like urine output is a little bit lower too, slowing down. Alrighty. Alright, so I'll come back in. I'm gonna leave for the day, but I will come back in and we'll check on you again. And I leave and then I come back in. It's 2 days later. Hi, Mrs. Ford. I'm Bailey. I'm your nurse again for the day. So I see that your output and your specific gravity has returned to a baseline. That's good. But your neurostatus is still at a 4 to 6, and that left pupil actually is at 8 millimeters and it's fixed. Your respirations are erratic, and I see your ISP is at 18, and your heart rate is dropping. And I put that the patient could possibly be her brain is swelling, which I know was an issue before, and that drain might not be draining, or there may be too much fluid, so that pressure is building up in her brain and it's not being released, or there could be hemorrhaging. So I would just check the drain, make sure everything's okay, make sure it is draining. Alright. Okay, so I'm going to give you some education, Mrs. Ford, and I will give you written instructions and repeat once your level of consciousness returned to normal. So when you do go home, you just need to limit your sodium containing foods because you do have high sodium levels. And what they diagnosed you with was diabetes insipidus. So what that is a secretion of pituitary hormone, vasopressin, is impaired, and it produces large quantities of dilute urine, and that's makes you have to go to the bathroom a lot, so your kidneys aren't functioning. It's not reabsorbing the water or your water urine. And the plan of care for you is to you need to monitor your intake and output, and we'll monitor your specific gravity. At home, you can watch your weight, and you want to monitor for any signs, symptoms of that you may be dehydrated, and we'll do the same thing here as well until you go home. And then I told you what desmopressin is, and told you things to look out for that. Alright, so if you have any other questions, you can push your call light, and I'll come back in and check on you to see how your level of consciousness is, and see how your levels are doing, and if you're getting any better. Right, so now I'm reporting off to my nurse. So I'd explain this is Mrs. Ford. She's 32-year-old female. She was admitted to neuro ICU 2 days ago because she fell, and because of that she had a large epidural hematoma on her left parietal lobe. She was intubated, has low level of consciousness. She has an EVD drain to monitor ICP. She also has an orogastric tube, and we put in a Foley catheter. Her vitals were 124 over 68. Heart rate was 84. Respirations were 16. Temperature was 98.9. MAP was 86, and ICP was 12. So her Glasgow Coma scale was at 6. She wasn't under any sedation. Her urine output was at 120 milliliters an hour. We gave her normal saline, 75 milliliters an hour, and tube feeds at 40 milliliters an hour. So draining was normal, pink, normal amount, 6 milliliters. Labs were sodium 155, serum osmolality was 310, urine specific gravity was 1.005. So then the provider gave some orders, ordered her desmopressants through IV push, so we gave that. Did a few free water flush via her OG tube at 200 milliliters every 4 hours. Changed her IV bag once it hit to 125, checking your daily weight. And then 2 days later, she's been receiving treatment, and her urine output and specific gravity had returned to normal, but she was still having her Glasgow Coma scale was still 4 to 6, and her left pupil was then at 8 millimeters, and it was fixed. And then her respiratory was erratic, her ICP was at 18, and her heart rate was dropping.